Is the screen visible?
Yes, sir.
Yes, sir.
Okay. So this is the 9 months old female child with peri-robin posted for cleft palate repair. And don't mention about the cleft with a gas roll and all those things in these cases. So
Okay, sir.
challenges to the anesthesiologist. This is an anticipated difficult airway, which is challenging to ventilate as well as intubate due to the dysmorphology in the patient. That is a small mandible, large tongue, and already existing airway obstruction. So maintaining a seal for ventilation using a face mask itself will be difficult in this case because of facial hypoplasia. Direct laryngoscopy and tracheal intubation tend to be very difficult during infancy. As the smaller the child, more difficult is this problem. But generally, as the child grows, the mandible also will grow, and then older children may not have that much of difficulty like the infants that you see. And the neonate with PRS may have increasingly sensitivity to opioids, so better to avoid any opioids in this case. And they may have OSA also because of glossoptosis during the time of their growing age from birth to up to say 9 months when you are going to operate. You must ask for history of OSA because of the large tongue obstructing the upper airway. So majority of the mothers will give you a history that I make the child sleep only in the prone position, otherwise she gets choked. So I will always put her on my lap in the face down position and pat her, and she will go off to sleep. And throughout the night she is comfortable only in this position. So this history is very important. And they may have feeding difficulties, swallowing disorders, and coexisting gastroesophageal reflux also may be there in this patient, which can lead to microaspiration and pulmonary infections. So preoperatively, you have to make sure that there is no history suggestive of any repeated attacks of pneumonia or pulmonary infections because of aspiration. And patients generally are malnourished sometimes because they are not able to be fed properly and have a high frequency of failure to thrive due to difficulties with feeding and airway, and maybe the weight gain may not be adequate for the age. So that is another important thing which will be challenging to you. Coming to the pre-anesthetic assessment, you have to ask about the birth history, whether the patient was born at full term or is a premature baby. Why the history of prematurity is important? When you want to do a surgery in a premature baby, what is the important post-op complication you have to anticipate?
Apnea of prematurity, sir.
Apnea of prematurity, fantastic, very good. Is there any method to prevent that happening? Any drug that can be administered?
Caffeine, sir.
Caffeine.
What is the dose?
mg.
20 mg per kg. Per kg. Okay?
Per
It is
kg,
not
sir.
just 20 mg, it is 20 mg per kg that can be given, which is available, can be given as oral as well as parenteral. And what is the post-op care that you have to take?
Supplement oxygen, sir.
Supplement oxygen. Monitor them. Prof apnea. Okay? 1 second. தகவலை கூப்பிட்டோமா கிளாஸ்ல இருக்கேன். Hello? Okay. So patients may go in for apnea and desaturate. That is the reason why they have to be monitored for the first 48 hours. That can happen anytime after 48 hours of surgery. So they have to be, even if it is daycare, you have to monitor them with a pulse oximeter all the time to avoid this complication. Then obtain history of patient symptoms, including recent URI, features suggestive of reflux, aspiration. All these things are important. And physical examination should make a thorough airway evaluation, and also cardiopulmonary examination and history of any OSA obstruction, how it is overcome. Of course, these children may not require CPAP or BiPAP, just a simple prone position, or sometimes surgeons to do what is called lip adhesion. They pull the tongue out and suture it to the lower jaw. That will way they open up the obstruction at the pharyngeal level, and that may also be one of the methods of getting over the OSA. And The other things is you must do the oxygen saturation measurement in room air to see whether they are already having any hypoxic episodes because of airway obstruction, and you should measure the heart rate, respiratory rate, and blood pressure of these patients. Now, preoperative investigations, it is just something like a routine one, CBC, electrolytes. In case of undernutrition, you have to do the electrolytes. Otherwise, you can do the routine renal functions, videolaryngoscopy in older children, of course, not in very small babies, chest X-ray and CT. Echocardiogram, if there is any murmur, indicative of congenital cardiac defects. Now, the challenges of airway management during anesthesia. This will be the main point of discussion in the exam. It is to maintain spontaneous ventilation, whether under sedation or general anesthesia. This is the most basic thing that you have to remember. Never paralyze these children. Upper airway obstruction is very common in PRS and relieved by two-handed jaw thrust by an assistant, or you can use adjuncts like oropharyngeal airway, nasopharyngeal airway, or laryngeal mask, or simple lingual traction. So these are all the methods of preventing the upper airway obstruction. And in cases of very severe airway obstruction and anticipated difficulty, it is always better to have a ENT surgeon who can do an emergency tracheostomy or bronchoscopy available by the side of the patient during induction. And techniques to secure the airway include laryngeal mask airway, fiber optic scope, and retrograde railing. Of course, this may be a little cumbersome in that. But direct laryngoscopy to intubate, you can use what is called right paraglossal approach, where you can avoid directly going through the oral cavity. You can go by what is called right paraglossal approach, which is more effective than the standard technique. And asleep fiber optic intubation, which breathing spontaneously is more safer, that you can achieve by inhalation of CO in oxygen. And for palate repair, oral ray tube is the tube of choice. And definitive treatment for this sometimes is lip adhesion. As I told you, pull the lip out and suture it to the lower jaw, or they do what is called mandibular distraction. In children who are not having a cleft palate, they may be brought for this particular procedure, what is called the mandibular distraction, to improve the size of the mandible by creating an osteotomy and then putting screws and rods and gradually expand the size by increasing the distance. And for that, you may need to do what is called a nasal intubation for this particular procedure. And anesthesia can be induced with sevoflurane and oxygen or intravenous propofol, preserving spontaneous breathing. Again, this point I am highlighting because it will be very disastrous if you paralyze the child and if you cannot ventilate the child also. Dexmedetomidine may preserve the respiratory drive, less incidence of apnea and respiratory depression and airway obstruction. That also has been used. And it is highly favorable for children born to have airway collapse and respiratory depression. These children are more prone for that. In short half-life, the dexmedetomidine half-life makes it a preferred agent for ambulatory pediatric procedures, CT and MRI also. That is what I told you in the earlier discussion also. Once airway is secured, the rest of the management is like any other palate repair case. Okay, so the mouth gag will be applied and mouth will be opened, and then there will be a gauze pack around the tube near the larynx to prevent aspiration. And the dissection may involve a little more amount of bleeding. So that can be avoided by infiltrating the mucous membrane of the palate with saline containing dilute adrenaline. Or you can use tumescent fluid also, we used to infiltrate in our experience in Stanley Hospital, which gives both post-op analgesia as well as very good hemostatic feel. Okay, so all those things are routine. So I'm not going into those details. So the exam point of view, these are the three important things you have to remember: how to manage the airway, and lastly the post-op airway obstruction is also very common in these patients unless proper care is taken. So in our children who are having pre-existing airway obstruction or with history of obstructive sleep apnea, chronic hypoxia, don't give any opioids for them for pain relief. Use as far as possible paracetamol or local infiltration in the blocks, more safer. So prolonged surgical duration, pressure exerted on the base of the tongue by retractors and airway edema, all of these are the causes of post-op airway obstruction. And complications are minimized by performing neck extension and jaw thrust alone sometimes, or introduction of nasopharyngeal or oropharyngeal airways. But after palate repair, many of the plastic surgeons do not prefer introduction of any airway in that because they feel that the suture lines may get dehisced or affected. So, but some people do say that gentle introduction of these airways is not contraindicated. And nursing the child in lateral position with a neck extension can also reduce the airway obstruction. Non-opioid analgesics, regional blocks, and local infiltration can help in preventing airway obstruction. So this is the NYSORA flow chart that is given. Induction, spontaneous ventilation maintained. Inhalation with sevoflurane, intravenous to propofol. Laryngeal mask airway can be used for preventing the obstruction, not as the main airway securing for surgery. And if you can ventilate, maintain spontaneous ventilation, prepare to intubate by pleural approach or medial laryngoscope or fiber optic through nose or LMA, depending upon the surgery. And maintenance with volatile opioid infusion, very short-acting opioid like fentanyl or remifentanil can be given, but not long-acting drugs. And alpha-2 agonist infusion like dexmedetomidine, and you can control the ventilation once the airway is secure. And during emergence, planned post-operative post-intubation, sedation to be continued in PICU. So this is the post-op management. But after induction by these methods, either inhalation or intravenous, if you cannot ventilate the patient, use oropharyngeal airway, two-handed jaw thrust. And if you are able to ventilate, and if it is a non-emergency, prepare to intubate by the same technique that you have, that either paraglossal videoscope or optic. And in case it is not, you are not able to ventilate, one more attempt at laryngoscopy or emergent rigid bronchoscopy, LMA or tracheostomy. That is the ultimate thing that you have to remember. So these are all the things that we have to remember with regard to this thing. Any doubts on that?
Sorry, while placing FOB, we can start with dexmedetomidine, then we'll go for our like we are doing in adults.
Yeah, you can do dexmed and then you can spray the adequate local anesthetic block is necessary for FOB. You know, just like, whereas inhalation induction, you can even without spraying or without local anesthetic, can take the patient to the adequate depth and intubate without topical. On the contrary, with dexmedetomidine, it is mandatory that you always do the topical spray as you go technique and block the reflexes.
Yes, sir.